Good afternoon. I appreciate this distinguished honor to speak at 2013 Congress of Korean Radiology. I sincerely appreciate the opportunity, but I also apologize for not being present in person. However, I'm there in spirits with you, and I wish you all a great Congress. These are my professional disclosures, but I also have some personal disclosure that I have a busy family life. I have two girls who keep us very busy with a lot of activities, and due to some child care coverage issues this week, I'm unable to travel to Korea. However, I promise to be there in near future. My family really appreciates your understanding, but also my dog and his friend. They like going for walks every day, and certainly they won't miss that. So thank you from all of us. Now, what we have learned in a recent past from various Nobel Prizes and other awards, that collaborations is a great way of advancing science. And these three unique scientists who have been awarded Nobel Prize in Chemistry come from different parts of the world with a very different background. But because of their unique collaboration, they made a great contribution to science and were awarded appropriately a Nobel Prize. And I think that also holds true for medicine in general, that collaboration is the key to success and for advancing science. And I have this unique opportunity of collaborating with physicians and scientists from various disciplines of medicine with a unique background. And I have listed some of the individuals that I work with, but there are several others that I routinely collaborate and are not listed here. But I would urge those who are not working in collaborative capacity to engage in collaborations, especially given the medicine is becoming so complex. Now, imaging has played a critical role in diagnosis and management of patients, and our efforts in last few decades have focused predominantly with CT and MRI on spatial and temporal resolution as well as image processing. Now, we have been able to get a high quality images that enable better diagnosis, better staging, and overall facilitate management of the patient. Now, cancer patients specifically have benefited a lot from these advances in imaging. Now, however, the treatments are changing rapidly. For example, if you look at liver cancer, surgery remains the standard of care, whether it's hepatectomy or transplantation. However, surgery is not always possible depending on the stage of disease and patient condition, and therefore alternative therapies like ablative therapies, targeted intraarterial therapies are routinely being used. There are targeted radiation treatments like proton therapy, and also there are some advances in chemotherapies which are being considered for a variety of different cancers. Moreover, there has been a lot of developments in chemotherapy regimens, especially the targeted therapies, and have been developed for a variety of different cancers, and we have witnessed approval of some of these drugs for specific types of cancer, but there are several other targeted therapies that are being developed and might be available for clinical care. Now, what is important with these drugs are they produce a very different types of effect than we are used to looking at our conventional imaging techniques. Now, we are also moving to the era of treatment customization because increasing evidence is suggesting that for a same type of diagnosis, if we give a similar treatment, the response is often different. For example, some of the patients in lung cancer of a similar histopathologic type might have toxic effects from the same treatment, whereas some who respond very well to these treatments. So clearly we need to recognize patients who will benefit better from the treatment so we can customize their management for the same type of diagnosis. Now, if you look at these two case examples of a small cell lung cancer, the only thing that is different for these two patients is the patient on the top row is EGFR mutant positive, and the patient in the bottom row is EGFR mutant negative. Now, both patients received same treatment, which is erlotinib, and you can look at the outcome is vastly different. The patient on the top row shows excellent response after treatment, whereas in the bottom row, the tumor remains grossly unchanged. So clearly, a better recognition of patients who will benefit is desired. Now, with these background, our expectations from our clinical colleagues is changing. They not only require a better diagnosis and staging, but also better tissue characterization to enable them appropriate treatment selection, and if possible, selecting the treatment early on within the initiation of therapy to ensure the right patient is being given with the right treatment, predicting who will do better, and also monitoring response to various new therapies. Now, functional imaging has a broad connotations. For example, our prior conventional radiographic exams like barium studies or IVPs or salpingograms were all functional studies. We could see the peristalsis, the reflux, and leaks and patency of certain areas. And so we are, as an abdominal radiologist, we have been used to doing functional imaging from the time the imaging techniques were being available. However, most of the functional imaging emphasis has been on a nuclear medicine type of exam. Now, next few cases exemplify value of functional imaging in clinical care. Now, 35-year-old patient whose MRI images are presented were presented clinically with hypertension, and a diagnosis of pheochromocytoma was considered. A MRI performed shows 2 lesions, one big lesion in the right side and a smaller lesion in the left adrenal. The bottom image is a contrast-enhanced image which shows enhancement in these 2 lesions. Obviously, the big question is if these are 2 pheochromocytomas or only 1 lesion is a pheochromocytoma, because management is vastly different, a single-site resection versus bilateral adrenal resection surgery. Now, this we cannot say for sure on MRI exam. Therefore, a MIBG scan was performed which confirmed activity in both adrenals. Therefore, a management of bilateral adrenal resection was facilitated based on the information provided with MRI and MIBG scan. Now, these are images from 2 different patients having neuroendocrine tumor with liver metastasis. MRI images confirm metastasis. Now, the real question is if we can give biologic treatment to these patients, and the response to this therapy is based on if patients are receptor positive, somatostatin receptor positive. So that information we cannot give them on MRI. So a octreotide scan was performed, and on the top right image you can see a positive octreotide scan confirming a diagnosis of a patient who can benefit from biologic treatment, whereas the bottom patient had no uptake on octreotide scan, so this patient will require other treatment approaches. Now, in tumor recurrence, especially after surgery or a combination chemotherapy, assessment of response from recurrence can be challenging. Rectal cancer is one such example. Pancreatic cancer is another area. We encounter that problem in the abdomen where it is difficult to discern recurrence from post-operative or post-radiation changes. And these 2 case examples highlight the value of using a functional imaging. The bottom patient shows a soft tissue abnormality, which we were not sure if it is a recurrence, but on a PET images, it confirmed a high activity, and that was biopsied, yielding a diagnosis of recurrence. Whereas on the top image, we did not see a morphologic finding on a contrast-enhanced CT scan, whereas on a PET, a focal uptake was seen in abdominal wall that in retrospect was present on this image on CT scan. So these cases highlight value of why functional imaging can overcome some of the limitations of cross-sectional imaging. Now, in response assessment, PET is increasingly being used. For example, in lymphoma, PET or PET-CT is now considered both for initial diagnosis but also selecting treatment for monitoring response. And many studies have shown that based on early response on PET or PET-CT, one can predict how patient will do at the completion of treatment and also the long-term outcome in these patients. Now, another area where PET is being used is in gastrointestinal stromal tumor, where changes in metabolic activity are considered much more sensitive in assessing treatment effectiveness. And here the case also highlights the limitations of morphologic imaging in accurately predicting response. As we can see, persistent soft tissue abnormality in the pelvis, whereas on PET images there is complete metabolic response at 1 month. So at 1 month we can predict who would do better at 16 months. Moreover, this experience has also helped in approval of this drug Gleevec from Novartis for gastrointestinal stromal tumor management. FDA is also looking at these functional biomarkers for assessment of effectiveness in other types of cancers. Now, with that background, there is high interest for developing functional imaging techniques along with morphologic methods. And certain advances in imaging, such as hardware advances, like we have better detector rows, so almost up to 320 detector row CT scanners are available, so we can scan a longer territory or cover the entire organ for a dynamic imaging. We have multi-energy CT capabilities. Hybrid techniques such as PET-CT, PET-MR, or SPECT-CTs are available that also offer functional and morphologic capabilities. Now, for example, with a multi-energy CT, we can acquire sequentially or concurrently two energies of different kVps. For example, 80 and 140 kVp X-ray beams can be transmitted through the patient. And since we know that iodine that is used in contrast media responds differently at two different kVps, we can extract iodine out of image, which facilitate better diagnosis and enhances patient care. Now, these are some of the case examples just to highlight how dual energy images can be used to advance patient care. For example, tissue viability can be better appreciated. Enhancement in area, for example, here in a Crohn's disease patient, the enhancement of the bowel wall is much more conspicuous on these dual energy iodine images. We can also manipulate these images to improve conspicuity of hypervascular lesion like hepatocellular carcinoma that helps us detect even the tiny hypervascular lesions here which were not visible on a conventional CT scanner. Looking at tiny hypervascular lesion in pancreas like neuroendocrine tumor, which was missed in the initial conventional CT scan but was appreciated on a dual energy CT. Differentiating a focal from a diffuse process, like in this pancreas, the pancreas appeared just swollen without any focal abnormality, whereas on the iodine maps we could see heterogeneity in the distribution of iodine in the pancreas, therefore helping us make a better diagnosis of a diffuse process. We can create a colored maps from iodine images which are very visual for diagnosis, but also iodine can be quantitated for tissue characterization, but also for monitoring response to therapy. So this is another diagnostic technique that can have a functional capability. Now, hybrid techniques, we are aware of the benefits of combining a cross-sectional details with physiologic or functional details. For example, PET-CT is very popular in oncology because now we can get a high-quality CT scan and overlay that with a functional images of PET, certainly fulfilling the obligations of diagnostic and functional exam for staging and better tissue characterization purposes. Another advanced is in imaging is hybrid PET-MR technique, which is increasingly being considered as a opportunity for better staging and tissue characterization, certainly overcoming some of the limitation that exists with CT scan like soft tissue abnormality or liver changes, where both CT and PET might not be able to detect. Bony abnormalities are better detected, and also the radiation risks are eliminated with the use of MR, and therefore in pediatric patients this is a technique that one should consider based on the evidence that will emerge in future. Currently this technique looks exciting, but the cost is the major impediment in its utilization, and we have to see how we justify these advanced imaging techniques. Now, other advances that we often ignored are the software advances, the new sequences, the better computational processes. These have certainly facilitated some types of functional imaging like diffusion perfusion imaging. MR spectroscopy is another technique, and MR elastography is another example where these advances has enabled us to capture information that was not possible in the past. Now let's look at diffusion weighted imaging, for example. Now we have learned from over last decade that certainly the knowledge we have from neuroimaging of how diffusion MRI can help us characterize tissue, because we know that malignant lesions restrict diffusion, so their appearance is very different than benign lesion. In summary, a malignant lesion will appear dark on ADC maps. Like here, we see these lesions which are bright on diffusion are dark on ADC maps, so one can characterize them as malignant. We see other lesions on a similar lines which are dark here, and this lesion in the lower row that is also dark. So clearly diffusion weighted imaging can complement the conventional MRI in better assessment of tissue characteristics and also improve detection. Now, how this can be used in clinical practice, I will emphasize with this case of pancreatic masses, and as we know that mass-forming pancreatitis is often a challenging diagnosis from adenocarcinoma of the pancreas, and we know the managements are very different. Now, on conventional imaging, there is limitation because of the morphologic overlap, but diffusion might be able to solve that problem for us. And this study that we did, but also on some of the publications on this topic, support that in significant number of patients. If we look at the ADC values between mass-forming pancreatitis from adenocarcinoma, the adenocarcinoma tends to show substantially higher ADC values as shown here, 1.9 in comparison to a lower ADC values of inflammatory process because of presence of some edema within these lesions. We can extend these efforts in better patient selection as we are doing more screening studies for conditions which are not necessarily aggressive at the time of diagnosis. For example, in von Hippel-Lindau disease, neuroendocrine tumor, if detected incidentally and are not having any hormonal changes, these lesions, if are of smaller size, can be conservatively managed till they reach a certain size where surgical intervention is performed. We can certainly consider using diffusion weighted images to see if these lesions, even though they are small in size, show restricted diffusion, and if surgery should be performed at an earlier stage than at a later stage. Diffusion weighted imaging is most interesting in evaluation of response to various therapies, and there are several publications in support of diffusion weighted imaging as a biomarker of treatment effectiveness. And what I'm sharing with you here is images from Ihab Kamal's paper looking at diffusion weighted imaging for predicting effectiveness of intraarterial therapies to the liver, and here diffusion changes could be seen within hours to days of initiating therapy, and the earlier changes predict how patient will do in long run, and what is the likelihood of a residual tumor or recurrence in a patient. So this is another case example and of using these functional imaging technique in better management of patients. Just to list some of the papers that are out there supporting the role of diffusion-weighted imaging in assessing tissue cellularity or aggressiveness of tumor. More importantly, I think as a biomarker of response and necrosis is that's most interest is in using diffusion-weighted imaging, and there are also studies which support that we might be able to predict survival based on early changes on the diffusion maps. Now, another functional imaging technique that I'm personally very much interested in is perfusion CT and MRI. And this technique involves a dynamic imaging after administration of an extracellular contrast, and then looking at the contrast wash in and wash out by applying a mathematical modeling and computation of that data can enable us to look at the perfusion parameters. Now, it is believed that the perfusion parameters reflect microvascular changes within the tissue. So benign tissue, for example, have a much more mature vessel, and malignant tumors tend to have immature vessel and a lot of leakiness and angiogenesis. So clearly their perfusion parameters are different than what a benign tissue would show. So this technique offers a lot of promise for tissue characterization, but also for assessing effectiveness of novel therapies. Now let's take this example of an animal experiment we performed here, looking at the insult in the pancreas. And here on CT scan, we notice a low density area in the tail of the pancreas. It's unclear if that's necrosis or edema. A perfusion map shows lack of vascularity, so confirming a severe insult or necrosis that often in patient requires a surgical intervention. So clearly an example of using perfusion imaging for better tissue characterization and risk stratification in this patient. We are also observing that the perfusion parameters can also indicate aggressiveness or underlying histopathology of the tumor. Now, this is a bar diagram of perfusion values of various liver tumors. And what you notice is hepatocellular carcinoma and metastasis from ocular melanoma shows a very high blood flow because these tumors are extremely angiogenic, followed by sarcomas, and pancreatic neuroendocrine tumors and ovarian tumors. So we can look at the perfusion values and predict the aggressiveness or angiogenesis, and certainly that information can help in deciding the type of treatment we give, whether anti-angiogenic therapy is desired for some of these patients. Now, an interesting area is looking at early anti-angiogenic effects, and this area is where I have invested a lot of time and effort investigating perfusion CT and MR for looking at early changes of these novel drugs. So, for example, this is one patient from a trial that we participated in, a patient with rectal cancer that were treated with anti-angiogenic therapy, Avastin, followed by chemoradiation and surgery. And you notice that after a single dose of Avastin, at 2 weeks, we can see changes in perfusion parameters by more than 50% drop in blood flow, whereas the metabolic changes have not yet occurred on a whole body PET images. So again, highlighting the value of perfusion technique as showing early microvascular changes that might not be obvious on morphologic as well as on metabolic imaging. We also confirmed our findings with established methods of angiogenesis, such as microvessel density count, and we noticed that whenever there was a drop in perfusion parameters, it also correlated with change in microvessel density count, as well as tumor interstitial pressure, another marker of tumor aggressiveness and angiogenesis. Now here we can see an example from a patient, a high power field microscopic image showing multiple vessels on an image, and these vessels look immature. And a follow-up after Avastin, we notice there are less number of vessels and they look more mature, suggesting that anti-angiogenic effects have occurred, and also these patients show changes in CT perfusion parameters, confirming the role of CT as a non-invasive surrogate for anti-angiogenic effect. Similar findings in patients with hepatocellular carcinoma, also treated with the same drug Avastin, and you notice that at day 10. There is no change in size, but there is precipitous drop in tumor blood flow in this patient as well as the patient in the bottom row, and these patients did very well at the end of treatment. And in the trial, what we noticed is those patients showing early anti-angiogenic effects with changes in blood flow, substantial changes in blood flow or increase in mean transit time, were more than likely to have a better outcome at the end of treatment. Now, similar findings we noticed with another targeted therapy, sunitinib, using a perfusion MRI, and what we noticed is you can capture these changes affecting tumor microvasculature with these drugs with using dynamic MRI technique. And here in these two case example, we show that in the bottom case there is a precipitous drop in K-trans of the tumor. Here there is a moderate change in K-trans, and during the clinical trial we noticed an average 38% drop in K-trans. And interestingly, we could see that patients who had much substantial drop in K-trans had a better response, such as partial response or stable disease, in comparison to those who had less significant change in their K-trans values. They had more likelihood of progression of disease. There is a lot of support for perfusion imaging in literature. These are some of the papers I have listed. I don't have time to get into each and every study, but the point I want to make here is blood flow is one of the biomarker with perfusion CT that consistently shows changes after therapies, whether anti-angiogenic or other targeted therapies, and mean transit time increase is another factor that people have shown as serve as a biomarker for response. There is ample evidence in the literature. Most of these studies are single institutional studies, though, validating the role of perfusion CT for better tissue characterization in different organs in the body, for assessing aggressiveness, or more importantly, by looking at anti-angiogenic changes for different types of drugs in different types of cancer and different body parts. So clearly a lot of interest and excitement in using this technique. Similar support exists for MRI as well, where changes on MRI, especially the permeability changes or K-trans changes, have shown to predict long-term outcome, but also response to various therapies in different types of cancers. Now, MR spectroscopy is another exciting area where we can look at metabolic changes within the tissue. And as we know that tumor tissue has a different type of metabolic composition in comparison to benign tissue or background liver parenchyma, and also if the liver has certain type of insult, it shows a different metabolites. And if we can capture these tissue metabolites, we might be able to predict not only the biology, but also use the MR spectroscopy for monitoring effectiveness of various therapies. Now, this is the data from our own experience, and what I want to share with you is if you look at the choline peaks of various tumor types, it is clear that neuroendocrine tumor, metastasis from ocular melanoma, and breast cancer metastasis to the liver show a very high choline peak, and breast cancer metastasis actually show a very high choline to lipid ratio, which is not seen in other tumor types. So there is some evidence to support that MR spectroscopy can serve as a non-invasive surrogate of tissue characterization and might replace biopsy in certain setting. More interestingly, I think early changes within the tumor composition, especially as a response to therapy, can be captured on MR spectroscopy. It certainly requires a lot of effort. As you can see here, the tumor before and after treatment shows changes in the choline peak as captured here. But interestingly, we can also look at early toxicity in the liver or fatty change on MR spectroscopy, because you look at the lipid peak that has increased a lot after treatment, just within few days of initiating treatment, and here we can see on in and out of phase there is slight fatty deposition. So there is an opportunity for us to use this MR spectroscopy concurrently with other MR techniques for better tissue characterization, but also looking at early toxicity. Certain types of treatments are available for impacting the fatty changes in the liver, because presence of liver fat makes insulin less effective in diabetics or patients who have HCV and HIV co-infection. So there are drugs that enable improvement in liver steatosis, like pioglitazone, and these pioglitazone can impact, within days of starting therapy and year, we can see a MR spectroscopy peak before and after treatment, and there is change in peak suggesting improvement in liver fat, which was not obvious on the conventional MRI technique. Other MR technique like MR elastography is something to consider for better assessment of liver stiffness, which is a surrogate for fibrosis and chronic changes. And this technique again requires a driver which gives a caustic beam that causes compression of the liver parenchyma, and based on computation of that data on MRI, we can get these stiffness maps, but also have a quantitative assessment of the liver stiffness in kilopascal scale. And increasingly there is data available from clinical trials which suggests that this is a sensitive technique in looking at various grades of fibrosis, right from F1 to F4, and MR spectroscopy is not only able to detect but also quantify fibrosis. So one has to watch out for this technique as an excitement. Other advances are more of a pharmaceutical advances. There are certain contrast agents that give us more tissue-specific properties to MRI. And there are drugs like secretin that enables functional assessment of organs like pancreas, and there are few receptor-targeted agents in development. For example, gadoxic acid or Eovist or Primovist, the contrast agent, is taken up by hepatocytes by following a certain transport mechanism, and this can be used for detection and characterization, but also looking at the cellular function as well as biliary function, given that this contrast agent is excreted in the bile duct. Now, just to show you example how this is used for better tissue characterization, for example, focal nodular hyperplasia and hepatocellular adenoma, two benign liver tumors, can have a similar morphologic look. Like here on contrast enhanced images, they look similar, but their managements are different, and here we see that focal nodular hyperplasia shows a lot of activity because of its function and preserved transport mechanism, whereas adenoma shows very weak or no visual uptake of contrast agent. This concept has also been extended in evaluation of liver nodule in cirrhotic patient, which is often a challenge because benign and malignant nodule can share some of the features, and also high-risk nodule might not be visible on conventional imaging techniques. Now, the hypothesis being that benign nodules have preserved transport mechanism and function. These will show uptake of contrast media, like here, this dysplastic nodule showing uptake, whereas malignant nodule typically lack this transport function, and therefore they will not be able to retain contrast. Like here, these three lesions are malignant lesion. There is a lot of interest, especially from Asia, where this technique is being used for better assessment of hepatocellular carcinoma, early detection of at-risk nodule before they are hypervascular on dynamic imaging, and also for improved diagnosis, even when an experienced reader is able to diagnose these lesions on the delayed hepatobiliary phase. Another area of interest with these new contrast agents is for staging patients with hepatocellular carcinoma. Now, this is a case example of a patient with no known risk factors presented with weight loss, and where here we see a big mass in the right lobe of liver, maybe something in the segment 4. It wasn't obvious as it is not arterially enhancing if that lesion is dysplastic nodule or hepatocellular carcinoma. So management consideration included a right hepatectomy and biopsying the lesion. Since this patient was not well physically, we repeated the MRI using a EOVIST, and what we noticed is that lesion in left lobe did not show uptake, confirming a diagnosis of a high-risk nodule, but there were another 30 nodules scattered within the liver that were not obvious on a conventional MRI and CT scan. So clearly highlighting the value how in a problem-solving situation these contrast agents are going to be useful. Biliary imaging is another interesting concept one needs to consider, especially functional biliary imaging with these contrast agents. Looking at anatomy or biliary insult like leaks after surgery. Here, as in this case, patient with cholecystectomy had a collection on T2 weighted image, and on delayed hepatobiliary phase we can see excretion of contrast. In this case, there was a tiny excretion of contrast, not even visible on the conventional images, and on ERCP we confirmed the diagnosis of leak. Certainly based on these images, non-invasively we can make a decision of who requires intervention or stent placement. Liver function imaging or cellular imaging is another interesting area for assessing insult to the liver or functional reserve. Like in this case with hepatectomy, there was some insult during surgery. We can see venous congestion, and on an MRI we can see reduced uptake of hepatobiliary contrast agent, confirming the loss of liver function in that area. We can extend these principles also to look at insult from other type of treatments like radiation treatment or certain drugs which causes hepatotoxicity. We can look at the changes or uptake in liver function and assess the extent of liver damage. Secretin MRCP is another interesting and exciting area where exogenous secretin causes stimulates the secretion of exocrine pancreas that can be used then to better assess the anatomy, integrity of the pancreatic duct, and if there is any communication, like in this case, here we can see a communication due to disruption of the pancreatic duct with a pseudocyst which requires intervention, and if there is no communication, then no intervention is required. So currently these techniques certainly are helpful in select patient types. Now in summary, what we have noticed is there is a evolution in medicine. There are a variety of promising treatments that are available, and these treatments demand a different expectations from imaging. We need to extend our efforts beyond morphologic imaging. Functional imaging information is desired for various indications, and some of the advances in hardwares, softwares, and some of the pharmaceutical drugs are enabling us some functional capabilities. However, there is no single functional imaging technique that complements the morphologic imaging and overcomes all the limitations. Most of the functional imaging techniques have a specific role. Moreover, we need to really validate these techniques. There are certain challenges with techniques. They are not routinely available and often expensive. They require a lot of expertise for protocol optimization. There are certain risks involved, like with CT-based technique, there might be slight radiation concerns. Some of these techniques have not been validated in the multi-center clinical trial. We also need a more reliable and robust methodology, so these techniques are reproducible and more quantitative. And with that, I thank you all for your kind attention. I hope, despite my physical absence, I have been able to make a case of how our imaging techniques are not only important today, they are going to play a critical role in future, and we need to be in the driver's seat. With that, I thank you for the invitation. Best luck.